on.
Recording in progress.
All right, sweet. Okay, so last time we started this lecture on cardiomyopathies, and I really tried to focus it on what y'all would need to know for IM boards. And like I told them, so all the information I pulled is from ACC-SAP, so it's not stuff that you're just going to read in MIC-SAP, but I used your MIC-SAP to kind of base off of what was important and what's not. And then, of course, even still, I put more things in there than like y'all really need to know. So I'll try to mention what's more in depth than what y'all need to remember. Classic specialist problem there, sorry. And then I've got some real life examples. So we did dilated and kind of like arrhythmogenic and restrictive last time. And so like also the first thing we always think about is ischemic versus non-ischemic. So we didn't really touch on ischemic because that's kind of our bread and butter, and we cover that more with, you know, just basic heart failure review. So we focused a lot on the non-ischemic cardiomyopathies. And so we went through dilated, we talked a little bit about arrhythmogenic, and we talked about restrictive, like your amyloidosis, your sarcoidosis, those kind of things. So today we're really going to hit on hypertrophic cardiomyopathy. It's a very big category because we know so much about it. And there's a lot of like specific medications and like specific things that boards want you to know as IM about hypertrophic cardiomyopathy. So if you have questions about the dilated arrhythmogenic restrictive stuff, I can go back and we can touch on that stuff again as well. And then we didn't record that one. So if we need to do it again, record it or something, we can do that as well. So let me go ahead and jump to the hypertrophic part. All right, so we'll start with a question. Some of y'all were here. I think we did this question, but we'll do it again. So this is straight from MIC-SAP. You've got a 36-year-old male. He is being evaluated for a 3-day history of progressive exertional dyspnea and palpitations. His medical history is notable that he has diagnosed hypertrophic cardiomyopathy, and he has mild MR. He's only on metoprolol. On physical exam, he's tachycardic at 116, and he's got an irregular pulse. Oxygen saturation is fine on room air. He's got some JVD. He's got a 3 out of 6 systolic crescendo, decrescendo murmur, and you hear it best along the left sternal border. And then the rest of your exam's normal. You know, these questions are long, so prepare yourself. You get an electrocardiogram, and you see AFib with RVR. So then you do a transesophageal echo, and you notice asymmetrical septal hypertrophy. You've got this dynamic LV outflow tract obstruction, and you see a gradient of 36 millimeters of mercury. There's no evidence of left atrial appendage thrombus. So when you do his CHA2DS2-VASc, it's 0. So they want to know, and as well as starting acute anticoagulation with heparin, what is the most appropriate therapy for thromboembolic risk in this patient? So do you do dabigatran? Do you do warfarin? Do you do high dose aspirin, or do you do no therapy? So Michael, what do you think? Yeah, that's what I tried to do. So it gives you time to think without feeling the pressure, right? All right, good job. Warfarin is the correct answer. So the big point they want you to take home, which we kind of touched on last lecture before we finished, was that in patients with hypertrophic cardiomyopathy, you ignore the CHA2DS2-VASc. So if they've got AFib, documented AFib, not all hypertrophics, but if you have documented AFib and hypertrophic cardiomyopathy, they still need anticoagulation regardless of their CHA2DS2-VASc. Now, this question, the answer is warfarin because that's what's been studied. However, in real life, you are probably going to use a DOAC. Dabigatran is almost never going to be the answer. And then, of course, no one uses high dose aspirin. If the aspirin is the answer, it's always low dose nowadays. And then the big thing is they were trying to trick people into picking no further therapy because his CHA2DS2-VASc is 0. So hypertrophic cardiomyopathy. This is a genetic cardiomyopathy. you got specific mutations in the cardiac sarcomeres, and it has variable expression. So not everyone looks the same. So sometimes you have sudden cardiac death. Some patients have significant heart failure. Some present with strokes. The definition is LVH that's not explained by like other abnormal hemodynamic things like loading conditions. So, you get LVH from hypertension, or if you've got aortic stenosis, so the LV is having to really squeeze against high pressures, the muscle thickens. Without those things, you shouldn't have LVH. When I'm looking at an echo, the specific number I'm looking at when I'm measuring is an septal wall thickness of greater than or equal to 15 millimeters. So just some general things. The estimated prevalence in a general adult population is like 1 in 5,000. So yeah, it's a sarcomere gene mutation. You got to look for family history. We'll talk more about that. Also, if someone has the family history and their wall thickness is 13 millimeters on echo, I'm going to still diagnose them as hypertrophic. Not something that y'all need to be too worried about, but just for your own information. And then, of course, it predominates in that intraventricular septum. However, there are variations. So you can have apical hypertrophs and other things that y'all are never going to see, probably, that we see and we have to be aware of. And it's that classic thing, if you talk about on echo, it's this like reverse sigmoid shape. So the base kind of the septum is like really thick and it kind of curves and gets thin again. So this is straight from ACC. This is kind of, your sarcomere, and it's just laying out all the different gene mutations. Nothing y'all need to actually be aware of. We don't even have to know the specific mutations, but just a little throwback to step 1 and 2. So the thing you want to know is first degree members obviously are at 50% risk of having that same genetic mutation. And then of course, 50% of patients have no identifiable genetic cause. So just because you can't find a gene doesn't mean that it's not there. And then when you have the truly genetic sarcomeric HCM, they tend to kind of aggregate, and those people have much more complications. So it's almost a good thing if you can't find one of the specific genes that we test for in these patients, because then you're you can tell, you don't tell them this, but they technically have better outcomes. So genetic testing, again, you just need to kind of know the highlights, which is the big thing, history, right? Get a personal and family history, do a really good physical exam, you get an ECG, you get an echo, all those things. You need to get them on a Holter monitor, right? Because oftentimes they may have paroxysmal atrial fibrillation and not realize it. And they're still at increased risk of stroke. And then we do these exercise treadmill tests. And then, we have the phenotype, which is just hypertrophic, but you have all sorts of other things. You have this interval scoring system that we use. And then again, when do you need to do genetic testing? Basically, once you have a diagnosis in a patient with first degree relatives and you screen them, if you find more first degree relatives, you should start the genetic workup. Not something y'all need to be worried about. At that point, you referred them to cardiology. And so we plug them in with a genetic counselor and do all those things. And I think there's only one in Chattanooga. So sometimes we send them to Emory or Vanderbilt for a lot of this stuff. And then we just follow them locally so that they don't have to always commute. But yeah, this is just kind of a basic overview. So what we do as a cardiologist when we get these patients. So yeah, big things, screen family members. If you ever have a patient that you see, even if it's just a one-time thing, always good to ask, hey, have someone talked to your family members, or has someone mentioned that your family members need to be aware of this too? Because sometimes, with our patient population, these things get missed. They show up once every now and then. So anytime you see one, go ahead and bring it up. And then when do you need to keep testing, right? If you have a family member who's normal, but you are worried that they're going to have it. So we say 1 to 5 years, depending on the age of the individual. And then the younger they are, you actually screen them more frequently. So as you get older, you're less likely to develop the phenotype just sporadically. So, and you, of course, the whole thing is now we have medicines to treat it and we have therapies. So you want to catch them young before they develop all the complications. So this is just something from ACC talking about there's like genetic mimicry with the sarcomeric HCM. There's like specific genes that they talk about like for other diseases. So things that are like the infiltrative that cause thick muscle, but it's actually not just the muscle thickening. So classic, it's like glycogen storage, like Fabry's or whatever, that causes deposition in the muscle and can make a really thick heart, but it's not the same as HCM that we're talking about. Another one I had to look up was like Danon disease. Again, nothing you're going to get tested on. These are just things that are important to know. So important, this is why we have other things that we look at. So with these infiltrative, the reason there's an EKG up here is because infiltrative, you actually have a different pattern on your EKG. So true hypertrophy, you have increased voltage on your EKG. So look how tall the QRS is, right? Massive, that's LVH, okay? Like in the traditional sense. If you have LVH and then you have low voltage, that's one of the things we talked about last lecture, keys us into maybe an infiltrative process, most commonly that we see amyloid, right? Because the way you think about it is you've got some other material in the muscle of the heart that's not conducting electricity well. So when you put an EKG on, it actually lowers the measured amplitude. Whereas when true hypertrophs, it's all thick muscle, so the amplitude of your electrical activity gets ramped up. So B is a still image, you can't really see much, but it basically is just showing, this concentric hypertrophy, and you can kind of see it better and see here. That's all muscle there. I've got a real echo from a patient of ours that I'll show you all later on. And then this last one is D, is an MRI of the heart. So what you're seeing is super thick septum. Maybe I don't know if I can, yeah, super thick septum. So the people who are on Zoom. And then when we do late gadolinium enhancement, it's just a protocol per the MRI, but basically you give them, that's like a contrast agent, and it lights up late on MRI. And then you see all this infiltrative disease. So this is not true hypertrophic cardiomyopathy. This is, what do they say? I think this is Danon's disease, whichever mutation that is, but it's an infiltrative one. So you won't see this. You won't see this on a true hypertroph. It wouldn't light up at the end. So your clinical criteria, again, so the big thing too, we get asked about as cardiologists that won't really come up for y'all, but it's something to think about just in general practice, is athlete's heart versus hypertrophic cardiomyopathy, because athletes obviously are going to have thicker, stronger hearts. So how do you differentiate? So one of the things that we talk about is LV cavity size. Again, this is for cardiologists specifically. You get those other focal patterns are going to differentiate them. You may have left atrial enlargement and hypertrophic, right? Because the pressure is going to back up and dilate your left atrium. Whereas in an athlete's heart, it's just the whole heart's remodeling to deal with the increased stress and strength in the heart. So your left atrium doesn't dilate. Bizarre ECG patterns. You've got, abnormal filling. Females, if they have a thick heart, you're more likely to think hypertrophic. Although if it's a true athlete, females can have thick hearts as well. And then family history, all those kind of things. Again, these aren't things that are necessarily going to be tested on y'all's boards, but so they did exercise training with these patients, because if you do see these patients, you want to know what you can tell them, right? So yes, please have these patients exercise. That used to be a board question for us, and not so much for y'all, but it was like the rule is don't exercise your hypertrophs. And now they say, no, moderate intensity exercise is good for hypertrophic cardiomyopathy. Now, again, you are never going to find a sports team that's going to say, yeah, come on, we don't care about your hypertrophic cardiomyopathy, because there's still an increase for sudden cardiac death and things that put a professional sports team at risk. However, it's not you can't exercise, so you can't play sports. It's just you can't play professional sports because of the liability. We do want them playing basketball regularly, one-on-one, whatever, golfing, running, just not pushing themselves to extremes. In this study, it's saying they looked at 16-week exercise program and they measured peak VO2 and just showed again that these patients did better overall when they had exercise, and it was significant. Here, again, we look at mortality is increased in patients with hypertrophic compared to their age-matched individuals, which we kind of all know, but this is just the data. We have tons of data, so we can actually prove these patients have, problems and they don't live as long. So we really got to be careful and take care of them and catch it early. This population was looked at from 1999 all the way to 2014. And you just see, once they get older, they really start dying more rapidly than other patients. Causes of non-violent death, again, this like sudden cardiac death we talk about in young people. The biggest thing is this unexplained, and it's not always hypertrophic cardiomyopathy, because you can see when we actually have diagnosed hypertrophic cardiomyopathy, it's pretty low, but it's still the unexplained is what we worry about. This was in a group of patients followed in New Zealand and Australia. So you need to be aware, but I think, we always get scared when we see these hypertrophic patients and we think they're just going to fall over dead one day. But it's not as common as just all the other things, unexplained coronary artery disease, even dilated cardiomyopathies. So the ESC is basically the ACC equivalent in Europe, the European Society of Cardiology. So they made this stratification risk score. This is just the data showing that if we use this risk score, it actually does improve patient outcomes and help us predict who's more at risk and how long they're going to live. Nothing you'll need to know specifically, but it's a good resource for us. All right, so now the important things. Who do we put a ICD in for HCM? For obvious things. Do they have a history of VFib? Do they have sustained VT, so not in SVT? Have they had a cardiac arrest? Do they need, that's all secondary prevention, right? They've already had an event, so it's not primary anymore, it's secondary. So that's class 1. Then you have major risk factors. So these are class 2 indication, meaning we still definitely put ICDs in all these patients. It's when you get kind of below the class 2A that it's kind of wishy-washy. Class 2B can go either way, and then class 3 is when we don't do the thing. So these patients all would get an ICD if they showed up in Manium's clinic. So first degree family member who died suddenly, kind of unexplained, and you've diagnosed them with hypertrophic, they're going to get an ICD. If they've had a recent occurrence of like a weird arrhythmia, or they syncopized and we don't know why they syncopized, and they have hypertrophic cardiomyopathy, we're putting an ICD in them. Extreme hypertrophy. So if I do an echo and their wall thickness is greater than 3 centimeters, we're putting an ICD in them no matter what. If they have an LV apical aneurysm, that increases your scar burden. Scar burden equals VT or VFib. So we put ICDs in them. And then if they have LV systolic dysfunction, meaning anything less than 50% EF, we put an ICD in them as well. That's important. Y'all should know that. It may not specifically come up on your boards, but as a good internal medicine doc, it's important to know. What other things? The ESC uses the sudden cardiac death risk tool that I showed you a second ago with the data points plotted out to help them just do that shared decision making. And then that model, essentially they had 3,700 something patients. And they showed that there was sudden cardiac death risk observed in 14% of the patients who fell into that high risk subset on their risk stratification tool. So it was helpful to know. All right, so AFib, we kind of touched on this. About 25% of patients will have an occurrence of AFib or aflutter, and they may not always realize it or feel it. And that's really common. That's much more common than your typical heart failure patient. And we think we see, heart failure patients all the time with AFib. So things to know are when you need to treat the AFib, we like disopyramide and amiodarone. That's kind of the most effective. So AFib has a very, very high risk of stroke for these patients. So 8-fold increase, I think, is what's been studied. And so the reason we like disopyramide, because we looked at these patients, because we talk about the other part of hypertrophic is HOCM, right? With obstruction. We kind of moved away from the term HOCM, and now we call it hypertrophic cardiomyopathy with or without obstruction. So that LV outflow tract obstruction is actually improved with disopyramide. So that's why we like to use it. It's a sodium channel blocker, just for review. And what it does is it increases your ventricular response in the AFib. So you kind of almost match up even though your AFib is still going fast. So it's not like a blocker where it's blocking the signal coming from the top of the heart. And if you're giving disopyramide, you always give a nodal blocker, like a beta blocker or something. But you can also use calcium channel blockers like the L type, whatever. Again, a little bit above what y'all need to know, but just important information. So obstructive hypertrophic cardiomyopathy is kind of its own thing that we talk about. Oftentimes what you have is, so the ventricle kind of moves in, it's so thick, it causes obstruction of the flow out the LVOT. So if you think about the heart, right, systole and diastole, during systole, the heart squeezes and blood moves through the LVOT out the aortic valve, and that gives you your stroke volume. Well, if your wall is so thick that it's squeezing and it's closing off the LVOT, your stroke volume is going to plummet, right? So you're basically getting someone who may have like, the equivalent is like a reduced EF, if you want to think about it that way. What's in their LV, even though if you calculated a volume and you did an EF off of their fractional squeeze and stuff, it may all be normal. But if you're blocking the blood from getting out of the heart, then you're not having an effective stroke volume. So you might as well be thinking about these patients as if they have HFrEF. This was doing this earlier.
The mic is on.
This one?
Yeah.
Maybe that's it.
See audio
Audio.
and you.
Volume? Mute. Okay, maybe that'll fix it. All right. So the way we look at this is with exercise echocardiography. So you don't want to give them pharmacological stress echoes. You want to actually exercise them and see how it does. And then what we do is we throw the probe on them and we measure that gradient in the LVOT to see if the patient is got a significant gradient. Mm-hmm.
I guess what's the difference in that case that makes the exercise better?
Yeah. So it has to do with the side effects. So like a lot of these pharmacological agents like amyl nitrate, dobutamine, or isoproterenol, they're vasodilators. And so that's also bad, right? We don't want like drop in all this other pressures and whatnot. So we want them to just like exercise to increase their stroke volume. And usually they do pretty good. And of course, these patients oftentimes have MR, right? Because their blood can't go through the LVOT, it's going to go backwards. Anything else? It's variable, right? So it can change day to day and hours, all sorts of stuff. They're very not symptomatic, but they notice things just based off of like dehydration, how much alcohol they've been drinking, the change in diet. All these things can affect their level of obstruction. So you have to be very careful with these patients. All right, so when you're thinking about HCM, this is just kind of a clinical breakdown. So first things first, you're going to just like treat other comorbidities, and then you're going to go, okay, do they have obstruction or not? So that's an echo, right? You start with a basic echo. If not, you're just going to do, GDMT for congestion, right? Because it kind of acts like a HFpEF. They just get volume overloaded, and you really want to get them on good diuretic therapy, and then you do all your classic GDMT. If they've got obstruction, are they symptomatic? Are they saying, I'm huffing and puffing whenever I try to walk or other things? That'll take you one way. If not, you just want to make sure you avoid any kind of vasodilators. And then you also have to kind of avoid high dose diuretics, which sucks because these patients get volume overloaded. So you get in a real pickle here. So if they are symptomatic, they do have obstruction, you definitely avoid vasodilators and high dose diuretics. And you really want to get them on a good beta blocker. You can use verapamil as well. Diltiazem can be used also. And if they're still symptomatic, on a beta blocker or a calcium channel blocker, that's when you're like, okay, now we're going to use some disopyramide, or do they need to go to a surgeon for septal reduction therapy? Again, all these things are at the cardiology level, right? So if you've got them started on a beta blocker, start them on a calcium channel blocker and send them to us, we'll take care of the rest. But some of these patients do need to have surgical resection. So are they a candidate? Then yes, they should have surgical resection. If you think they're a bad surgical candidate, you should do an ablation.
For the
Mm-hmm. Mm-hmm. Yeah, it's not specific. It's honestly, you're going to talk to your surgeon. You're going to do like the STS score to see how high risk they are for surgery and go from there. But there's not direct cutoffs as far as age and whatnot. It all just depends on, do you think they're going to do well with surgery? What are their other comorbidities? So this ablation is actually really interesting. What they do is, it's like doing a cath. They go in, they go through the coronary, and then the septal perforator branches that come off your LAD, they literally inject alcohol in them and cause them basically to die. And they kill the muscle that way. So it feels like they're having a heart attack. So it is not a fun process for them. But surgery is also a big thing too. So you don't want them to just go through surgery if they're not going to do well. So that's kind of the end of the line as far as treating the obstruction. Other things, oh yeah. So verapamil theoretically can be used, but you need to keep it kind of in the back pocket, right? Because it's not great with advanced heart failure, volume overloaded. If they have like really bad obstruction at rest, we try not to use verapamil. But theoretically, it's in that class of calcium channel blockers with diltiazem that you could use it. It's just one we don't favor. All right, this is just some data. So there's a study called the Explore HCM trial, and they looked at this new drug, and it's mavacamten, and it's coming out probably in the next few years. And it basically, all this numbers just show that patients had a decrease in their LVOT obstruction gradient, in their biomarkers, and basically everything when they were on this drug compared to if they were not. So it's like a phase 3, I think. So it's almost ready to go out to market. So you'll be seeing more of that going forward. Just interesting. All right. So for those of you zoomed in, I apologize. I'm going to show them an echo, a really good echo of a patient of ours. And let me see if I can log back in. I still have the information, but I cannot switch the Zoom from my laptop to the Erlinger interweb. And the presentation was too big to email to myself. So, all right, let's pull up this patient. Any questions while I do this? There she is. Yeah. All right, so I'm going to switch it out. It's not like me doing this.
Actually, I have a question on that.
Yeah.
I had a question of that on my board.
Yeah. Okay.
So,
Good to know. All right. So normal or abnormal? Abnormal. I'll give you that. All right. Ash, why don't you kind of walk me through this since you're gonna have to do this. So what view am I in? Okay. So I'm gonna point to structures and I want you to tell me. Oh yeah, there you go. Kind of what space I'm in. So what is this little space up here? Nope. Above that. So this is a little pericardial fusion. Okay. So what's this then? Yeah, so that's my RV. All right. So then what cavity is this? LV. What's this? What's this little spot right here? Yeah, or I can't tell if the valve is actually here or it's probably the LVOT, but what's this then? Yeah, so that is the septum. That is her septum right here. From here to here is her septum. And then you can even see her RV right here is super hypertrophied. So that's bad. She's got some brightness here on her mitral valve. So I would say it's probably some mitral annular calcification, but you can see her posterior wall doesn't look as thick down here. So it's just her septum. All right. Next view, kind of the same thing, really just highlighting how thick that septum is. So they zoom in on the valves, nothing to look there. All right, so now we're getting some flow, some Doppler flow to look for mitral regurg will be coming down this way. And then you want to see if there's a gradient here, which you don't measure it here, but this turbulent flow is not good, right? The blue and yellow and red mixing means that there's some kind of interference with the flow that should be going out there. So she's probably going to have obstruction. All right, so measured our outflow tract, nothing to be worried about there. Another view. All right, so now we got some measurements. So her septal wall is 1.84, which is not that bad compared to what I thought it was going to be. They probably could have measured a little bit more kind of up here, but it's hard to say where the RV would be and where the LV kind of walls end. And then again, you can see her posterior wall in this view actually is thick as well. So we didn't see it earlier, but it's still there. All right. Just some more measurements. They tried to measure the cavity there. I don't really know if that's a good measurement or not. And then just measuring the sinus of Valsalva. All right, M mode, don't need to be worried about that. All right, just a view. So this would be a tricuspid view, kind of a tilt on your plaques view. So you can see that it looks like there's a little TR. We'll look at it better. There's a Doppler through there saying, yep, there's a little TR jet. Oh, whoops. All right, so now another fun view, right? So what view is this? Anyone? Yeah, external short axis, right? So we get the full cavity, and you can see this baby is just thick. So what they typically do is they start towards the apex, and you're going to again get another view in the short axis at the papillary muscles to represent the mid cavity, and then you'll get a view up near the mitral valve leaflets to kind of represent the base of the cavity. So very, very thick. You can't even really see, there's RV, but it's not really there. So you can see the papillary muscle right here. So this would be mid cavity. And then these little flappy things right in the center should be your mitral valve, your anterior and posterior leaflets, but you can barely see them just because of how thick the muscle is. So now you're in your short axis, but you're the very top of what we consider the base. So you've got your LA down here, you've got your RA right here, and then you've got your RV here, and then your aorta sits right in the center. So it looks like there's some calcification on her aorta, but nothing bad. And then you got a shiny thing in here, which is her lead. So she's got an ICD probably, or some kind of device that's going through. So her tricuspid is right here. And so the device kind of goes through there. And again, you can just see that it's very thick. This shouldn't be as thick as it is. And she's got thickness everywhere. She thick. So again, again, little TR jet here. And let's see if they measured it. Yeah. So again, kind of the same numbers we were getting before. Mild TR. Looking at the pulmonic, no obvious jet here, so probably no pulmonic stenosis or regurgitation. And it's Dopplered it as well, and I'm not worried about that. Again, trying to show us a zoomed in view of the aorta. So a little thick, does look trileaflet, although it's hard to say. Just takes a lot of looking at these sometimes to tell. And you can see there looks like a little jet right here on diastole, which might be some aortic regurgitation, but it's hard to, you can't really call this view. Here we go. All right, so what view is this? Haruka, what view is this? Yeah, apical four chamber, right? So you've got your LV, very thick, got your RV, RA, and your LA. LA is very dilated, right? Because all that blood that should be going out the aorta is going back probably into the LA. And there it is. You can see a nice MR jet, and it's wrapping the wall. So we would say that's probably going to underestimate how bad the MR is. Yep. So yeah, they tried to Doppler the MR here, and that's bad. You should not be at 6 meters per second backwards. And then this is just to measure the forward flow, and then try to zoom in on it to see if we can see anything. And then they do some more measurements for us. All right, so now they're giving us a LAVI, or a left atrial volume index. Normal LAVI should be less than 32. Hers is 51. With that severe dilation. All right, and so this is just measuring. So when your mitral valve opens, it opens and there's an E and an A. E is like your forward flow, emptying, E for emptying, and A is A for atrial contraction. So you get two flow waves. So that's what you see is the first wave here is your E wave. It's just emptying into the LV, and it's small because it's already hitting a bunch of fluid and pressure, so it's not getting very far. And then your A wave is really high because your atria is trying to contract to push the rest of the fluid forward. So just we use those for markers of diastolic function. So she's got bad diastolic dysfunction as well. And now they're trying to look at tissue Doppler again. That's just for our diastolic function. More views here. Now they're trying to isolate the right side. So you can see that TR, again, just mild TR. And it could just be because she's got a, lead going through the valve. So TAPSE, this is a measurement we use to determine the function of the RV. So her TAPSE is high, which means her RV is still squeezing really good, which is what we expect. And then more measurements for the RV. So the RV, we get a basal measurement. It's a little large, but nothing bad. And then if you looked at the RV to the LV, right, the RV is still smaller, so probably not RV dilation. Now they're just looking at the septum of the two atria to make sure you don't see an obvious jet across the septum. And now they're trying to bring in the outflow tract and the aortic valve. So this is your aortic valve right here. You can see it's bright because of that calcium. And you can see all this turbulent flow. And so they're just trying to optimize the best view. And now they're going to start trying to Doppler. And so what we do is, you can't really see it here very well, but they Doppler with points all along the septum as they get close to the outflow tract to find the highest gradient. So there's one, there's another right at the below the valve, and then that's through the valve, so we can get a stroke volume and everything. And now they're going to start looking for gradients. So there it says LVOT. I love when they measure it. Tell me exactly what they're looking at. And then they're saying now they're up here at the base, and there's a gradient there as well. And now they're saying they're kind of measuring. Looks like it's right there, but they said base. I think they forgot to get rid of it. But so they're just checking the gradient. So this wave is showing me high flow, turbulent flow through that area. In the mid cavity, the gradient goes down. So it's mostly at the base and then some at the apex. And then, yep, as you go to the apex, it's all gone. So Valsalva, right, increases our gradient. Yeah, so lots of measurements. So now they're trying to get a 2-chamber standard, again, just to look at the mitral more. And then this is our 3-chamber. It's kind of like a parasternal long access done at the apex. So you get a little bit of your RV, and you get your LV and LA real well, and you get your aorta good. So they'll probably repeat all the measurements here. And now we're doing our subxiphoid or subcostal. You can see a little bit of liver right here. And then this is your right side now, and this is your left side. So just look how thick that heart is. You can tell the right's really squeezing. There's a little bit of a pericardial effusion. You can kind of see that lead going through the right atrium into the RV. And you can see a much larger left atrium. And just another view. Again, so you always do Doppler in this view because the best way to find a jet that shouldn't be there is going to be perpendicular to the beam of the Doppler, not parallel. So in this case, right, if the Doppler is coming from the top of the screen, it's cutting right through the intraatrial septum here, almost perpendicular. So if there was a PFO or some kind of communication, the jet would show up much better in this view than it would in any of the other views. Checking our IVC, it is, what is it, 2.9, so almost dilated. Let's see, looks like it's collapsing, so. And then they tried to do the arch for us. And now they do their measurements. And so, oh, her EF's normal, it's 77%. I'm sure she's fine. But as we talked about, it's not going to be normal, even though the EF is normal. And that's it. All right, so let's jump back and do a few practice questions. All right. I'm going to have to new share. Okay, let's do this. Oh. My screen looks very different than that. Escape. What? My screen is not. And my screen. Okay. Zoom share that. Yeah. Oh God. Okay. My screen does not look like that at all, so I can't tell what is going on. So let's do. All right, so I'm just going to ignore my computer and try to do it this way. Okay. It fixed on my screen. Okay. All right, question 4. All right, Haruka, you're up. So we have an 18-year-old male. He's evaluated for participation in sports. Okay. So he's going to college. He's got a basketball scholarship. But he says he has no symptoms. His medical history is unremarkable. He doesn't take any medicines. On physical exam, his vitals are normal. Oh, but you listen to him. He's got a brisk carotid upstroke. Then he's got a grade 3 out of 6 systolic crescendo, decrescendo murmur. It's heard best along the left sternal border. And when he squats, because you thought maybe I should have him squat, it decreases. And then, of course, if you have him in the upright position, it's more pronounced. His lungs are clear. So you get an ECG, and it shows voltage criteria for LVH, and the repolarization is abnormal in those ST segments, but it's not elevation or anything. So you're like, we should get an echo. So you get an echo, and you're like, he has asymmetric septal hypertrophy. His thickness is 18 millimeters, so higher than 15. And then they say there's systolic anterior motion of the mitral valve. So what's happening is the mitral valve opens during diastole, right? Because that's when the LV fills. So your mitral valve, your anterior leaflet shouldn't go towards the septal wall during systole, because during systole it should be closing. But when you have obstruction, that anterior leaflet gets sucked up against the ventricle because it's so thick. So that's bad. So systolic anterior motion of the mitral valve is a classic sign for hypertrophic cardiomyopathy and should make you be worried about obstruction. And so then they do a peak instantaneous outflow tract gradient at rest of 30 millimeters of mercury. So which of the following is the most appropriate management regarding the patient's participation in basketball team? So do you tell the patient to do moderate sports activity? Do you start a beta blocker? Do you refer him for septal alcohol ablation? Or does he need a ICD? Okay. Okay. So you want to say A? Yeah, good. Yes, A. So again, you're not going to tell him he can't do his basketball scholarship, but what you're going to say is, well, here's how much activity you can do, right? So 2-a-days, hell no, like any of that stuff. But you should be playing basketball, enjoying your life, exercising, doing those things. And then it will be up to the college team and everyone to decide his risk level and all that stuff. And then also refer to a cardiologist, because it's probably got a sports cardiologist they're working with to kind of risk stratify and whatnot. Beta blocker, again, not a bad option. But like we said, the first thing is he having symptoms? And he's not having any symptoms, right? So, and then septal alcohol ablation, again, that's like down the line, right? So we've tried beta blockers, we've tried disopyramide, all those things, and he's still symptomatic. Then we start thinking about septal alcohol ablation. And again, he has no history that we're told of to make us think that he needs an ICD. Now, if he said, oh, I syncopized last week, I don't know why, or, oh yeah, my brother died at 30, and we don't know why, all those would be reasons for an ICD. All right, question 5. Mims, you're on cardiology, so you'll do this one. You got a 50-year-old male. He was diagnosed with hypertrophic cardiomyopathy. He had an episode of syncope. So they do an implantable cardioverter defibrillator, and they start him on metoprolol. He gets genetic testing, and he has a mutation in the beta-myosin heavy chain gene associated with hypertrophic cardiomyopathy. So his medical history otherwise is unremarkable. He has a 16-year-old daughter who is asymptomatic. So which of the following is the most appropriate management for this patient's daughter? So do you want to get an ECG and echo screening at 21? Do you want to get an ECG and echo screening at 40? Do you want an ECG and screening if symptoms develop, or do you want to do genetic testing and counseling now? Yeah.
So seems like the daughter would be higher risk, even though she's asymptomatic. So I don't think you would wait until 40.
Nope. Good.
I don't think you would wait until symptoms develop.
Good.
And I think I would, some community.
Yeah.
I would probably say, probably go with D.
Yep, D. Good. So we have a father with known diagnosed with a genetic variation that we know of. So we're going to test her for it because we want to keep her from ever developing symptoms and ever having heart failure. So if she has the gene, then we're going to start screening really early. If she doesn't have the gene, we're still going to screen, but maybe not as frequently. So, but the big thing with this is screening early, frequently when you have a genetic test positive. And if a family member has a positive genetic test, everyone in their immediate family should get genetic screening. So now if the father didn't have the gene, you would probably screen everyone with an echo and then decide how often you need to keep seeing patients based off of their age. Okay. All right. So kind of to wrap things up, you're going to see a lot more genetics come into play in the future. Yeah, what's up?
So if dad has a known gene,
Mhm.
daughter does not carry that same gene, she would still be at risk of other genetic variants?
Potentially. So it doesn't say she, like you're not going to say she's never going to have hypertrophic cardiomyopathy just because there's a lot of genetics we don't know, right? So you're going to still screen her, but not as frequently and as often.
Got it.
Yeah. And that would be more for a cardiology level question. Like you just need to know you screen her once and then go from there. I'm the one.
Just because she doesn't have that gene doesn't mean, oh, you're good.
Yeah, it doesn't. It does not completely rule her out. So she should still probably get plugged in with a cardiologist just to see every so often and make sure she's doing well. Yeah. So yeah, genetics are going to become more and more important. We're getting more and more. So this is also, sorry, this is for all of our cardiomyopathies. So going back to amyloidosis and our restrictive cardiomyopathies, amyloidosis, we have treatments now. So we're testing for it more. And so the prevalence and incidence is going to go up because we're finding it more, and it's actually a lot more common than we realized. So keep it on your brain when you start seeing these patients. CMR utility is going to go way, way up because not only can you look for like the infiltrative things, but it can do these cool flow assessments, and you get really good data on regurgitation or stenosis and other things like that. So you'll see more and more cardiac MRI. You're going to see continued attention as far as these arrhythmic risks go, especially like we talked about hypertrophic cardiomyopathy and some of the weirder ones. And then we talked about that one, there's novel treatments coming for patients with the obstructive hypertrophic cardiomyopathy. So be on the lookout for those things. So take home points. Sudden cardiac death or sustained ventricular tachycardias always need an implantable cardioverter defibrillator for secondary prevention. If you have a patient with hypertrophic cardiomyopathy who has symptoms and you're worried about outflow tract obstruction, start with a non-vasodilating beta blocker, so metoprolol. And then you want to get a transthoracic echo every 24 to 48 hours. Every 1 to 2 years for the asymptomatic patients. It's like an ambulatory ECG as well, they wear like, it's kind of like an MCOT, but we have like a little patch now that we can put on. You'll probably have seen them in the hospital. And then the whole constriction versus restriction, you're definitely gonna get tested on that. Constriction, think caged heart. So all of the stiffness is on the outside of the heart, but the inside still works fine. Restriction is thick. You got thick heart muscle and it just can't squeeze at all because it's all inside the muscle and everything. And you got an infiltrative problem. And that's it. Any questions? All right. Well, we will wrap up here. That is in Amsterdam. I got to Amsterdam right before Omicron came through. So I got lucky, went with some friends to a little vacation. And Campbell showed a sad face because he didn't get to look at the echo. All right. And we'll end here.